Hello, Dr. Banis. Thank you for joining us on MD Newsline podcast. Can you please introduce yourself to our audience?
Hi, I'm Dr. Dylan Banis. I'm an OB-GYN practitioner in the South Side of Chicago.
Wonderful. Thank you for joining us. Like I said, I just want to kind of get started and understand what do you think right now are the most pressing clinical challenges in modern OB-GYN care, and how do you approach them in your practice?
It's a very interesting question. I think the most pressing challenges are actually not even clinical. I think what we've seen over the past decade, 2 decades, is an explosion in the amount of information and the techniques that we're able to perform as obstetric practitioners. However, what we tend to lack is the ability to implement all of these different techniques and different ideas and thoughts into our day-to-day practice. I'll give you one example from when I was actually going through medical school. That was around the time that we changed all the guidelines for cervical cancer screening. However, it took decades for people to even start to implement those different screening methods in their day-to-day practices. Even today, day to day, I have patients who are still requesting more frequent screening than they actually need. And that's just due to this lag time between an innovation and actually being able to implement that innovation into a day to day practice.
Interesting. And then how do you approach patients actually requesting services like that, and how are how's the latest research and evidence-based guidelines being incorporated into patient management strategies as OB-GYN, and then just on the outpatient side, people kind of seeing something new or having things that used to be done in the past and then requesting them to doctors? How does that work?
Of course, I think it starts with listening. It's one of the skills that I don't think we actually learn in medical school to the degree that we actually need to learn it. But I think that if we can start with just listening and trying to understand where the patients are coming from, it oftentimes leads to a much better conversation, much more shared understanding, both from the practitioner's point of view as well as from the patient's point of view, what actually needs to get done.
Mm. And I know there's so much advanced technology and new applications coming out these days. What recent advances in gynecological or obstetric medicine have most changed workflows or treatment decisions, and how have you seen them implemented?
There's a lot of work being done to address the large causes of morbidity and mortality in obstetrics.
Mhm.
One of the leading causes of death is actually hemorrhage at the time of delivery. So, any sort of technology that we have to be able to predict hemorrhage and to mitigate those risks are things that we try to implement as quickly as possible. So, there's a lot of work being done on the technology side when it comes to hemorrhage management and also hemorrhage prediction. And those are the things that we try to implement.
Interesting. And there's so many different techniques for giving birth,
Mhm.
from doulas to kind of indigenous methods of giving birth. Is this, squatting versus laying on your back versus C-section, induction, things like that. How are you navigating those conversations with patients as they plan kind of their birth journey?
Of course, again, it starts with listening.
Mhm.
Everybody's going to come into this experience expecting something slightly different. The way that I went through residency, I was trained by a lot of certified nurse midwives. To be able to understand these different techniques was right in line with the way that I was trained. So giving birth on all fours or in a squatting position, being more mindful of the patient's wants and desires is something that I often find leads to better birth outcomes, even if things go south. So what I mean by that is if we come in with a certain plan and let's say the baby is not really behaving in the way that we want them to, and we have to go to a cesarean section or something of that nature, if we already have a good relationship where you know that I'm listening to you and you know that I'm trying my best to actually respect your wishes, that decision to go to a cesarean section actually happens much more quickly and much more efficiently because we've established this trust based on listening.
Can you talk a little bit about collaboration with multidisciplinary teams in complex OB-GYN cases like high-risk pregnancies or oncology referrals?
It's incredibly important, but also incredibly difficult to do efficiently. One of the largest causes of medical errors is actually that transition between things that I know and the things that I want to impart to another practitioner. So having a good, efficient way of communicating with another specialist is, again, something that's difficult to do. But we're making really good advances when it comes to information sharing through technology, number one, and also being able to build those relationships between institutions who might have a resource that one of our patients might need. For example, I think you mentioned oncology as one of the specialties, excuse me, that could be very important to refer a patient to. So, as a community practitioner in a community hospital, gynecology oncology services are not generally available right in that institution. However, we have very close relationships with our partners at the academic centers in the surrounding areas. So we try to smooth out those referral patterns as much as we possibly can, so that no patient really falls through the cracks.
Mm. And how does information transfer play into all of this? Because I know that can be a bit delicate. Are there any gaps that you're seeing in the system, and what are some of the solutions that you have seen kind of come into play or that you hope to see implemented?
Yeah, I think once electronic medical records were conceptualized, that was the big thing that everybody was looking forward to. If I put everything into a computer system, then obviously, or at least our hope is that we'd be able to get all of it out again and be able to share it freely among the people who actually need to know this information. What has happened instead over time is the market and capitalism, basically. I don't want to seem like a socialist. I'm not a socialist by any stretch of the imagination. However, I will say that there are a lot of economic pressures that lead a software company to develop their product in such a way that it becomes difficult to share that information with another software company. So something like Cerner, which is an EMR, to Epic, which is another EMR, there are ways of sharing information, but it's very disjointed, it's very labor intensive, and sometimes it's actually inaccurate. So it becomes imperative for us to develop new techniques and new methods to ensure that those methods of information sharing become a lot more smooth over time.
Hmm. So I want to talk a little bit about health disparities in underserved populations. But first, let's talk a little bit about birth giving age, which
Mm,
is always a hot topic of discussion.
mhm.
What are some of the biggest misconceptions that you see about the age at which a woman decides to start that journey?
Well, first of all, it's a personal decision.
Hmm.
And I think we always need to start there and remove judgment from the conversation first and foremost. There are some objective things that we need to be aware of when it comes to giving birth over a certain age. And we generally use the age of 35 as that cutoff. It's not really a cutoff, it's more of just an inflection point. That's how I at least try to term it. So things like Down syndrome become a little bit more prevalent the higher that you go. Different birth complications also get up there a little bit more than we'd like to see. But if you're a competent practitioner, you understand these risks, you're able to communicate those risks to your patient, you just deal with it over time because every bad thing doesn't happen to every single patient. But you just have to make sure that you're prepared to deal with something like an obstetric emergency.
Hmm. And what are some of the most common complications that you see, even outside of birth age being something that kind of factors in? Are there some kind of common complications that you see in birth, and has that changed over the years at all as far as trends go?
You know, the one of the largest causes of death in obstetrics is hemorrhage at the time of giving birth. And that's usually been the case, and it's always been one of the leading causes of death, is actually obstetric hemorrhage. That has not changed as much as we'd like it to. Other things such as preeclampsia and stroke that's related to preeclampsia, birth injuries as well that's related to things like nutrition and even getting proper prenatal care. Those are the things that we attempt to address over time.
Let's talk a little bit about things like socioeconomic status too. What are some of the differences in birth outcome that you see that seem to play along socioeconomic status trends?
Of course, I think that's a wonderful question, and it's a very hard question to actually answer effectively and accurately. Everybody has their own sort of preconceptions, everybody has their own ideas about what actually impacts labor outcomes. Socioeconomic status is actually a really large driver of that for multiple reasons. One, it makes it more difficult to access care.
Mhm.
And most of the time during prenatal care, it's a long battery of screening tests meant to detect things before they actually become very large problems. If we're missing our prenatal appointments, that means that there's no opportunity to screen. And oftentimes these issues get worse and worse over time. And by the time you can kind of actually catch it at the time of giving birth, it's oftentimes too late to do anything about it. You just have to do your best to mitigate those circumstances. So, when it comes to things like nutrition, that's driven by socioeconomic status very strongly, a very strong correlation between the two. And that has a very, very large effect when it comes to your birth outcome. When it comes to things like obesity, those tend to be correlated to socioeconomic status as well. And to be able to address that at its very root, it takes a much deeper look at a patient's life than we actually have time to go into during a 5 to 10 minute discussion at your prenatal appointment. So there's a lot more that needs to be done when it comes to addressing these different drivers of health. And I'm excited because I think we're paying a lot more attention to it as well.
How have you seen technology be implemented to kind of deal with that patient education side of this entire journey? Are you seeing any effective ways technology is being used, or are there any implementations that you hope to see in the future?
Yeah, I think one of the biggest things that we started to do and really started to push was the idea that a patient owns their own medical record. All the information contained therein actually is about you as a patient, so it makes sense that the patient has access to it. I think the conversations that are happening about healthcare with patients should obviously include the patient, but not only the patient, but also their family. And I think although we are starting to pay a lot more attention about getting that information to the patient, we need to include the entire family unit into that discussion because they have a lot of influence into actually what happens. One big example is actually with tobacco use. If I counsel a patient about their own tobacco use and let's say that they stop, but their partner still smokes, their rates of, kind of going back into their old habit actually goes up exponentially because of that. And also the idea of secondhand smoke and thirdhand smoke, those things are only addressed in a family system. They cannot be addressed just one on one. So any technology that includes the family dynamic, I think that's the next step in information sharing and technology to accomplish that goal.
And do you find that, that doctor's visits are so short and it seems like there's so much information to get through? Do you find that there's enough time to get through that information? Or when you look at the lifespan or the relationship of information sharing and conversation, what do you hope to see as far as creating space for more in-depth conversation, or what's missing there?
Yes and no. I think there's both not enough time and a lot of time at the same, junction. And what I mean by that is, yes, your visit with your physician might be 5 to 7 minutes or so, but we have an entire care team, and to be able to involve that entire care team into something like prenatal appointments is something that I look forward to seeing more of. One of the It's not even a large innovation, it's something that we know works, and that's called centering in pregnancy. And I don't know if you're familiar with that concept, but really truly it means that we do group classes with our patients. Everybody who is of a certain gestational age, they'll get around into a group, they'll have an opportunity to ask questions of an expert on that topic. So let's say that we're talking about something like domestic violence. So we might have a domestic violence advocate or expert give a talk about that topic. And you'd be very surprised. Maybe you wouldn't even be surprised about it, but the act of one person asking a question often prompts a lot more questions that people might not even know that they had. And so then you get a much more enriched environment where you're able to glean more from that discussion. We need to do more of that, obviously. But even outside of the concept of centering in pregnancy, employing people like doulas in those prenatal appointments, a certified nurse midwives in those prenatal appointments, or even the medical assistant, empowering them to have more directed and focused conversations with the patient. That's how we actually enhance healthcare. It doesn't have to center around the physician, although I know we like to think we're the center of the universe. It doesn't have to be like that, and it shouldn't actually be like that. It's a true health team that's taking care of a patient.
Speaking of this conversation about doulas, just basically anyone assisting with birth that's not a physician, um, people are either on one extreme or the other. And I feel like there are a bunch of maybe misconceptions about what that process is like. What are some of the most common misconceptions that you hear regarding, you know, birth being facilitated or assisted by a non-physician, and how do you maybe navigate that? What are some of the systems that people might not know about that exist for certification training, and how might a person like that work hand in hand with a physician to ensure a safe delivery?
I think there's a very large gap in knowledge with the providers when it comes to, I don't want to call them ancillary staff, but people who are assisting in the birthing process. One of the biggest misconceptions is that either the doula doesn't know what they're talking about, or they're going to get in the way of my plan as a practitioner for this particular patient. Saying things like they'll just try to convince you out of a cesarean section, even though we know that the cesarean section is necessary. That's one of the largest things that I see among my own colleagues when it comes to doulas. But the reality is much different than that. I think obviously getting to know the support staff is something that as practitioners we don't do enough of. We need to understand their background, we need to understand their certifications, things that they're comfortable with, things that they might not be comfortable with, because it is a practice of healthcare. And I would be remiss if I were to suggest to you or anybody else that I know everything. I clearly do not. I don't think anybody knows everything. We can all learn from each other and our shared experiences. And every single day that we go into a patient interaction or even an interaction between providers, the goal should be to actually learn and understand and improve our outcomes day by day.
hmm We've talked a little bit about food, and we've talked about things like secondhand smoke. What are some of the other environmental factors that you discuss with patients? I'm thinking even mostly about like pollution and particulates in the air. These are kind of areas of research that I don't think a lot of people know about, depending on socioeconomic status. There's maybe a factory nearby somewhere. Are those conversations being had with patients, or is that staying mostly in the research world?
It's very difficult to have that conversation with patients because in that small snippet of time that a provider might have to have a discussion, there's a lot of information that needs to get covered. And there's also a lot of information that we might not even either know about or ask about. So, developing different risk scores for different zip codes is something that we can do as a healthcare industry so that we start to understand those different environmental factors. I love the fact that you brought up pollution and your proximity to, let's say, like a factory that's polluting the air or the water or something of that nature. Those are factors that we don't necessarily take into account when we're having these discussions with our patients. And then even when we're looking and we're examining the different outcomes that we get at the end of the healthcare journey or at the end of the delivery, those different factors are oftentimes not taken into consideration at all. And I think that we need to.
Interesting. Are there any other systemic barriers you see affecting women in underserved populations, and which clinical practices have you come across or technologies that are effective, if any, in overcoming them?
I think one of the largest barriers, it sounds very basic, but it's actually the idea of self esteem. It's the idea of imparting the knowledge and the wisdom that you are worth everything in the entire world. There's nobody more important than you when you're having that discussion with your provider, and you shouldn't take no for an answer. You shouldn't take confusion for an answer either. If there's a question that you have as a patient, being able to empower you to ask those questions and continue to push until you actually get the answer that you deserve is a skill that is not often taught to anybody. So, especially when it comes to a cultural difference, everybody has their own backgrounds, and I also know that every culture has its own proclivities as well. It's not a bad thing; it's just the way that things are. And some cultures are naturally more inquisitive, and they press and they push a little bit more than other cultures who might just accept an answer for being an answer. I think that there's a middle ground that we need to strike there somewhere so that people understand that, if you truly don't understand, tell us that you don't understand so that we can explain it a different way so that you are able to actually understand it.
Yeah, this is a conversation that I'm seeing across the board, especially when people are even asking questions on places like social media, to where it's almost like, how do you know what to ask your doctor if you don't even know what your options are?
Mhm.
How are you finding that patients are able to gauge the quality of care that they're getting? Are people going to usually one source, or is it just if you don't have a doctor in the family, then you just kind of have to rely on what you're told by your physician?
Difficult question to answer.
Mhm.
I think people get their information from a lot of different sources. It used to be, I'm going to date myself a little bit, but it used to be WebMD was like the big thing that people always used to go to. Now it's Google, now it's ChatGPT or, Gemini or something of that nature. Again, it's not a bad thing. I think having the understanding that the information is out there and everybody deserves to know this information, nobody should really have a monopoly on that discussion. That's first and foremost the biggest thing to understand. But I think my wish would be that people would do more research on their own, actually,
Mhm.
and come to their providers and their practitioners with more, succinct questions and concise questions about what is actually bothering them about either what's they're going through right now or what questions do they actually have that they wish that somebody would explain the answer to them. Um, Again, like I don't think people do enough of that. And as the information superhighway, so to speak, expands at an exponential rate, that's one of the things I think is going to be challenging for physicians. But I think it's a challenge that we need to take on head on.
Mm. Sometimes when I hear doctors talk about that conversation of patients doing their own research and kind of that patient education communication piece, it almost sounds like there needs to be like an additional thing in between. What does that look like for you? Is that AI? Is that an additional patient advocate when it comes to making sure that the patient really has all of the information and understanding of what is actually going on? Is there enough time to do that regularly? If you were to design maybe like an ideal way where those conversations would take place, what would that look like?
Yeah, I think that again, wonderful question. I think this is one of the uses of AI that we should continue to explore. The idea of translating the medical jargon that physicians try to get away from, but it's quite difficult. Quite difficult, frankly, just to be able to translate those words in your own head and then speak them out loud to a patient in the way that they understand. And then you add in a language barrier or a cultural barrier or an education barrier into the mix, and now you're just floundering in no man's land. So being able to use AI to translate a physician's note and the medications that are prescribed and the care plan and the next steps and the significance of those next steps, I think that's a wonderful use of technology to be able to construct a summary that we can give to a patient that they can actually understand and react to is another wonderful use of AI that I hope to see in the very near future.
hmm do you foresee any barriers to kind of that type of information sharing, even maybe across institutions, as patients may go from one place to another? And what do you hope to see, or what is being developed that might address that issue?
Yeah, there's a lot of barriers to that. And I think there's a misunderstanding in information security and actually the concept of privacy as well. Um, One of our biggest things that I wish never happened is let's see, how do I term this properly? It's really the idea that things should stay locked up in a silo forever. Your conversation with me should remain sacred and it should only be between you and me. Nobody else should know. And on one hand, sure, that makes sense to go down that route. But when it comes to the way that healthcare is actually delivered in 2025, that's not necessarily relevant anymore because our patients, they go everywhere. They go from one institution to another and they might give birth somewhere else. So being able to quickly and easily share that information from institution to institution then becomes imperative. And I think the idea of silos that are kind of predicated upon the idea of security, that needs to be revisited. There's a lot of ways to implement security protocols and privacy protocols that respects the patient, but also makes it so that the information is freely shared among the people who actually need to know,
Mm.
and among, I guess, during the time frame that they actually need to know it.
I'm curious when it comes to the research arm of everything. AI is being used to look at previous clinical trials and things like that. But I'm also I know that in the process of developing a study, there have to be checks and balances when it comes to patient information. I'm wondering if you maybe foresee a world of more free flowing information that might accelerate the world of research, using artificial intelligence and machine learning, considering the red tape that already exists.
There's a lot of red tape. But AI is a wonderful tool for taking a lot of information that's out there and then consolidating it into something that people can actually understand and react to, and actually implement different therapies and solutions based upon that analysis. The issue that we have is actually with, the first part of gathering all this information, making it so that it's in one place or in multiple places that we know about, and it's also accessible to the people who are developing these different research protocols. There's a lot of work, a lot of conversations that are taking place even today about the best way of doing that. It's sad to say we haven't really reached a conclusion to that conversation, but just the fact that we're having the conversation about how do we make it so that the information that we're gathering every second of every single day is made available in some way so that we can actually move the healthcare industry forward at a much higher pace. Healthcare is one of the slowest moving industries in the entire United States of America, and it's partially because of this fear of leaking information inappropriately. And if we can start to understand what that fear is based upon, and then do our best to develop different protocols and trajectories so that that doesn't actually come to fruition, then we're going to be in a much better place.
hmm How do you see cost playing a role in things like information sharing and transfer, or even maybe insurance? I know there's a lot of red tape around people even having access to their medical information. Seems like it's a little different process between institutions. Um, when it comes to this type of kind of care communication, whether it's in the birthing process or another, as far as cost and insurance goes, how do any of those things, if at all, play into that process?
For information sharing,
Yeah.
or okay, specifically, yeah, I mean, I think um, data is actually very expensive, but also very cheap. We value it very high, but the entire process of moving data points from one place to another actually does not cost very much at all. However, the places where you see the most costs usually has to do with the institution itself and the way that their data systems are actually set up. A lot of institutions have legacy data stacks, or technology stacks is what we kind of call it. So that's comprised of like your EMR as a core, but also is comprised of things that you use to register a patient. Your pharmacy might have a different software that they use. Your billers might have a different piece of software that they use. The list goes on and on and on and on. And you can imagine a hospital that's been around since, the 1950s. They've gone through multiple different iterations of what that software might look like. The issue is that people don't tend to remove an entire data stack and then replace it with a different technology stack. It's more of like a bits and pieces and bits and pieces that are coming out and then getting redeveloped and getting inserted back in there. What that leads to is a very disjointed way of handling information that leads to a lot of different inefficiencies and a tremendous amount of cost. Data right now and software right now is relatively cheap compared to how it was, maybe 10, 15 years ago. 15 years ago, 20 years ago, we're all on servers that were embedded or installed at a hospital. And you'd have to hire like IT staff to maintain those servers. You'd have to have an entire team of individuals ready to do that. But nowadays, most services are on cloud provisions, and that makes it a lot cheaper and a lot easier to modify and actually make things a lot more smooth. So as we kind of move towards that paradigm, and we're kind of shifting from the hospital owning the infrastructure to software companies owning the infrastructure instead, I think we're going to see a lot more momentum towards that ideal situation where information is freely shared, it's freely given, freely accessed by the people who actually need to access it, and we're able to actually move forward on that premise.
What emerging technology implementations or research regarding OB-GYN or just information sharing in general are you most excited about?
Well, I think one of the biggest things is the idea of robotics in gynecological surgery. Um, when I went through residency, I trained on a robot. Since then, there have been multiple different iterations of that same technology that makes it much simpler to perform surgery. The outcomes are much better, and the techniques that you can actually employ while doing surgery are incredible. So being able to take hold of things like that, um, I'm very excited about things like like robotics. But there are also different techniques that my colleagues in other specialties are actually developing. They're actually very helpful to women in my practice. So things like fibroid embolization, excuse me. Um, Classically, what we used to do as gynecologists, everybody gets a hysterectomy. You have bleeding issue, do not pass go straight to hysterectomy. I'm simplifying, obviously. It's not actually like that, but the emphasis was on that definitive management of that problem. But now there are so many things that we can do, so many different medications that we can try, and so many more minimally invasive techniques that we can employ to help our patients. It almost makes it so that hysterectomies are even further down the line of your strategy for helping a patient through their issue. So being able to incorporate more techniques like that are things that we should definitely stay aware of and stay ahead of.
Wow. Well, this has been an amazing conversation. Thank you so much for joining us here on MD Newsline Podcast.
Thank you.